Hello, everyone, and welcome to today's webinar, Not Your Average Tick Talk, an overview of tick-borne diseases and the diagnostic landscape. I'm Cassie Saltman of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more, go to www.us.diasorin.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speaker for today's webinar, Dr. Kenneth Gavina. Dr. Gavina is an ABMM certified clinical microbiologist with the Indiana University School of Medicine. He's an assistant professor of clinical pathology and laboratory medicine and currently serves as the medical director of clinical microbiology and serology for Eskenazi Health, as well as a clinical consultant and technical supervisor for the IU Health Division of Molecular Pathology. His research interests revolve around molecular diagnostics, diagnostic stewardship, novel assay design for emerging infectious diseases, and developing affordable point-of-care diagnostics for use in low-resource settings. Dr. Gavina, you may now begin your presentation.
Thank you, Cassie, for the introduction. And I want to thank LabRoots as well as DiaSorin for hosting the webinar and inviting me to speak today. I'm going to apologize in advance if my voice starts to go. I think it's a combination of coming down with a bit of a respiratory illness, as well as yelling at my TV last night while my hockey team was losing the game. So let's get into it. These are my relevant disclosures. I do want to mention that while I do discuss some of the diagnostic platforms during this webinar, they are not an endorsement, but rather just stating what is commercially available on the market. I'd also like to mention that I am receiving compensation for this webinar from DiaSorin. However, the information presented in this webinar is of my own opinion and does not reflect that of DiaSorin or my employers. So, these are the learning objectives for today. The first one is going to be talking about the pathogenesis, the clinical presentation as of common and emerging tick-borne pathogens. We're going to describe what the epidemiology and the geographic distribution looks like for many of these tick-borne infections in North America, as well as relevant trends and emerging threats. And then we're also going to discuss some of the diagnostic challenges associated with trying to identify these tick-borne infections and some of the emerging technologies on the horizon. So let me kick this off with a question. Why should we care? Well, for one, tick-borne pathogens account for the majority of vector-borne diseases in the US, significantly more than mosquito-borne and any other vector-borne disease combined. From 2004 to 2022, the annual number of cases of tick-borne diseases rose from roughly 22,000 per year up to more than 84,000 per year, so marking nearly a four-fold increase in the disease prevalence. Now, you might ask, why has there been such a dramatic increase in the cases of tick-borne diseases? And I don't think there's a simple answer to that question, and that, in fact, there are multiple factors that contribute to the increase in prevalence. The first is that we are now getting better at looking for these diseases, and that alone is going to inflate the number of reported cases. Secondly, there's also been a growing number of tick-borne agents that are recognized to cause disease in humans. And thirdly, the concept of One Health, which is the approach that recognizes the interconnectedness of human, animal, plant, and environmental health, very much plays a role in tick-borne diseases. I really like this figure here taken from Al-Kishi and colleagues, where they used data from the last century to create a predictive model of temperature changes over the next 25 years in the future. These environmental changes have not only radically changed the geographical range of tick vectors, but also looks like these trends may continue for the next few decades. Additionally, human interventions such as deforestation and urbanization has also resulted in fragmented areas of land that create densely populated tick environments with increased interactions with both humans and preferred hosts, such as white-footed mice or deer. I always like to give a bit of a disclosure, or viewer discretion is advised whenever I give a talk like this. Ticks themselves are kind of gross, and the thought or visual image of them tends to produce an itching sensation in most people I've given this talk to. I love this image of this poppy seed bagel because I think it really gives you an appreciation of how tiny these ticks are. And when we discuss them further, the damage and severity that they're capable of impacting onto human health. I like to use a case-based approach to illustrate disease and discuss context of whenever I'm teaching or lecturing about a subject. So what you can expect during this webinar is a case study example for each different tick-borne pathogen we'll be discussing today. And here's a little bit of a roadmap of what you can expect. So there will be a lot of tick pictures. There will be a few images of different rashes. And for those of you who find yourselves scratching during the webinar, sorry. So let's jump into it with our first case. A 12-year-old female presented to her primary care physician with a fever that has lasted several days. She has no localizing symptoms except for the development of this odd rash on the back of her leg. Her history was notable that she lived in Connecticut near the New York State border and had recently been walking through tall grass with her older sister. So what is on your differential diagnosis? We can see a very classical bullseye-shaped rash here, otherwise known as erythema migrans. So I'm not trying to trick you. This is directly to the point. This is a classic example of what Lyme disease may look like presenting in a patient. Lyme disease is caused by a bacteria that belongs to the genus Borrelia, of which there are nearly 40 different species, many of which cause pathogenic disease in both humans and animals. All Borrelia species are arthropod-borne. In the case of Lyme disease, they are harbored by the hard-shelled ticks, specifically Ixodes ticks. Another arthropod-borne Borrelia species that you might be familiar with is Borrelia recurrentis. So this causes relapsing fever and is transmitted by the human body louse. So in this figure here from the CDC, it's showing us the geographic distribution of the black-legged tick Ixodes scapularis. In the US, which is the primary vector of Lyme disease. One important note, though, on this map is that it does not show the distribution of another tick, Ixodes pacificus, which is the western black-legged tick, also capable of harboring Lyme disease. So Ixodes pacificus is it spans in the ranges of the Pacific Northwest in the state of Washington, all the way down to California, and even starts creeping eastwards towards Colorado. So the disease itself is transmitted from the saliva of the infected Ixodes tick when it latches on and feeds off of the host. Similarly to mosquitoes, only the female ticks will engorge for blood meals and are typically the only ones that will transmit disease. There are a few characteristics that will allow you to distinguish the Ixodes tick from some of the other ticks that we'll see today. And the first is that they present this oval dorsal shield on their back, otherwise known as a scutum. And that only goes halfway down the back. So you can see this black shield here on the figure on the right. The second is that on the reverse side, they also have a very prominent anal groove, which kind of looks a little bit like a horseshoe right around their anal pore. So these are two very characteristic features of Ixodes ticks. The most common etiological cause of Lyme disease in the United States is Borrelia burgdorferi. And the clinical course of Lyme disease can really be separated into three distinct stages. So the first stage here is your early localized acute phase. So you might see a skin rash. You typically will have nondescript symptoms like fever and fatigue. And then this goes into the second stage, which is your disseminated stage, where it goes beyond kind of that initial site of acquisition. You might see multiple skin rashes throughout the body, joint pain, muscle fatigue. And then, of course, you have your late disseminated stage, where you might have neural involvement or CNS infections, so stiff neck, meningitis. You might also see some discoloration of the skin. This is known as acrodermatitis chronica atropicans, or ACA, as well as substantial joint pain across the body. So for the diagnosis of Lyme disease, serological methods remain the gold standard for testing. Specimens should be collected under sterile conditions and transported and processed immediately by the laboratory. The recommended sample type for non-serological specimens or non-serological based methods will greatly depend on the clinical presentation and at what stage of the disease the patient is in. So for example, in those early localized stages, if you want to do some kind of direct detection or maybe molecular based method, you're ideally going to want to try and get some kind of skin biopsy, preferably around that bullseye rash. So punch biopsy on the encroaching margins could work. Similarly, in stage 2 and in stage 3, skin biopsies work great if the rash is still presenting on the patient. However, if you are having neural involvement and are concerned of neuroborreliosis, CSF might be a suitable specimen. If you are seeing cases of ACA or joint pain, synovial or joint fluid may also be an acceptable specimen. So the CDC recommends a 2-tiered testing strategy for serology. The first usually involves some form of immunofluorescence assay or EIA, and this is going to be looking for IgGs that would respond to the rickettsial antigens that are specific. If those screen positive, there's going to be a reflex test specifically to immunoblotting that's going to confirm your infected case. Now, it's important that we have this tiered testing modality because it's that second test that's really going to confirm whether or not this is a true case of Lyme disease, as that initial EIA or IFA test tends to have some interaction with other rickettsial infections and other bacterial infections as well. So an example being treponema can cross-react with our Lyme results. It's also important to note that this serological-based testing method is going to be largely dependent in terms of effectiveness depending on which stage the patient is presenting in. So early on, you're not really going to anticipate any production of IgG because that does take several weeks to produce. You're only going to be able to detect IgM for the most part. Stage 2 and stage 3 is when you start seeing those IgG antibodies produced by the host immune response. Okay. So on to another, one thing I want to go back and talk about really quickly here is the treatment modalities for Lyme disease. So the drug of choice is going to be doxycycline. However, an alternative drug would be the penicillin as well as second or third generation cephalosporins. It's important to know that there are no established guidelines for AST testing and interpretations of MICs for Borrelia. However, there's been a lot of studies that have demonstrated pretty good agreement with in vitro susceptibilities and clinical infection. Okay, now let's move on to the other case. So we have here a 63-year-old female who was admitted because of rash, body aches. 6 days prior to admission, she had noted the onset of severe head and body aches followed by exacerbation of arthralgias. 4 days prior to admission, she noted that the onset of a rash beginning at her legs began spreading to other parts of her body within 24 hours. The patient has had a history of significant times outdoors, gardening, handling flowers, and then approximately 2 weeks prior to her presenting at the hospital, her husband had removed a small tick from her ankle, which is represented in the image below. So, what is on your differential diagnosis? This is a case of Rocky Mountain spotted fever, and the culprit that we have here on the right is the dermacentor tick, otherwise known as the American dog tick. If we remember what our black-legged or Ixodes tick looked like, there are 2 major distinguishing features on the dermacentor tick that can help you identify the difference. The first, again, is looking at that dorsal shield on the back. We can see that it tends to have this white-colored or marked scutum. And then the second is, I'm not sure if you can see it, but towards the end or terminal end of the body on the tick, if you look closely, you'll see or notice these notched ridges. These are known as festoons. So dermacentor ticks possess festoons. Ixodes ticks do not. Okay, so Rocky Mountain spotted fever is caused by Rickettsia rickettsii, not to be confused with Rickettsia prowazekii, which causes epidemic typhus and is transmitted by lice and not ticks. Rickettsial bacteria are obligate intracellular bacteria that require to be in some kind of host cell. So they will grow in the cytoplasm of eukaryotic cells. And while they aren't classically considered a gram-negative bacteria per se, they kind of have their own little category. They do possess a gram-negative cell wall structure that contains both a lipopolysaccharide as well as important outer membrane proteins OMP-A and OMP-B. It is the most common rickettsial disease in the US, with more than 500 cases reported each year. Unsurprisingly, most of these cases occur between April and October, so spring, summer, and early fall. American dog ticks are the reservoirs and vectors for disease. And as for clinical symptoms, they tend to be fairly nondescript. So fever, chills, headache, abdominal pain, muscle fatigue, and some joint pain. You will tend to see rashes that form at the extremities and then begin to spread to the trunk. So one kind of memory mechanism I like to try and remember about rickettsia rickettsii is that you can imagine that you're holding like a racket or like a racket, whatever. And you can imagine that the rash itself is going to start in your hand if you're holding that racket, and then it spreads to your body. So the bacteria themselves, they infect endothelial cells. This increases the vascular permeability, which then produces these focal hemorrhages or the rashes that you see in the body. If the disease is allowed to progress, it can be quite severe and fatal. You may have symptoms that include both respiratory and renal failure, as well as neurological development and encephalitis. So I really like using Rocky Mountain spotted fever as an example of the growth of the geographical expansion of the tick-borne vector. So on here on the left, you can see the reported cases of Rocky Mountain spotted fever as of January 1st, 2010. On the right here, you can see the two vectors that are competent vectors for rickettsia. So you can see it covers a substantial portion of the geographical United States. And if you compare that to below, you can see that there's quite an expansion of the number of reported cases. So this is the number of rickettsial infections reported in 2022. And again, looking at the seasonality of it, you can see that they are predominantly within those warmer months, so April through October. And as temperatures start to get warmer and warmer, you can imagine that this range of seasonality is only going to broaden and expand. So for molecular-based diagnostics, whole blood, plasma, buffy coat, or tissue are all appropriate specimens. However, similarly to Lyme disease, the organisms tend to sequester within the tissue at the site of inoculation. So while diagnosis from fluid is possible, a punch biopsy of the petechia or the maculopapule or the margin of the eschar is a preferred specimen type and is usually collected as the gold standard specimen. It's also possible to observe the organisms directly through the use of immunofluorescence or special staining in histopathology. So a Giminin stain, for example, is a good stain that you can use to visualize these bacteria, albeit they have a much lower sensitivity compared to PCR-based methods. Most diagnoses of rickettsial infections are through serology and include a variety of methods such as immunofluorescence assays, latex agglutination, as well as the whale Felix test, which is a serological test that utilizes the similarities of rickettsial and proteus-based antigens to determine positivity. Now, while there are no commercially available FDA-approved PCR assays for rickettsial infections, most LDTs or analyte-specific reagents that are available will often target the outer membrane protein gene, so OMP-A, OMP-B. Now, as far as treatment goes for rickettsial infections, the drug of choice is doxycycline. Now, I've heard doxycycline been referred to as vitamin D because it's kind of used ubiquitously for some of these atypical bacterial infections. So it's good for fighting Rocky Mountain spotted fever. You know, it's good for fighting a lot of things. So we're gonna be seeing this bottle of vitamin D quite a bit throughout this lecture. Okay, case number 3. A 7-year-old male who was transferred from an outside hospital 4 days previously with complaints of fever, malaise, headache, and myalgias was admitted because of respiratory distress, hepatitis, and pancytopenia. His family owns several exotic animals, and they reside within the southeastern United States. Bacterial, fungal, and AFB cultures were all negative. Viral, respiratory, and pneumonia syndromic panels were ordered and were also negative. A blood smear was performed, and the following was observed. What is on your differential diagnosis? So here in this image, I am showing you a Giemsa-stained thin smear. We can see some red blood cells there, as well as some peripheral blood mononuclear cells, or PBNCs. But what is of particular interest is this one band cell here. And if you look at the inlet of the image there, you can see another example a little bit better. It's this band cell with this strange intracellular body. So this intracellular body or vacuole is known as a morulae. And this ended up being a case of ehrlichiosis. So Some background about Ehrlichia and Anaplasma. They belong to the same order of the causative organism of Rocky Mountain spotted fever, so Rickettsialis. Again, they are gram-negative, obligate intracellular organisms, so they require another host cell in order to be able to replicate. In this case, they create these cytoplasmic vacuoles that we see on the slides here. These are known as the morulae, and they replicate within those. These are zoonotic agents that are transmitted to humans following a tick bite. And it's important to note that both Anaplasma and Ehrlichia produce a very, very similar clinical presentation. So it's usually going to be some kind of influenza-like illness, usually accompanied with leukopenia or thrombocytopenia, as well as elevated liver enzymes. So the causative agents, let's start with human monocytic ehrlichiosis or Ehrlichia. The causative agent is Ehrlichia schafiensis, and the vectors are the dermacentor tick, so the American dog tick, as well as the Amblyomma americanum. So we have a new player at the table. This is otherwise known as the Lone Star tick and has two distinct features, again, to help you kind of tease it apart from some of the other ticks. The first is this very distinctive white spot on the back of the dorsal shield that you can see here. And then the second, again, is looking at those terminal ridges at the body of the tick, so those festoons. So the Lone Star tick does have festoons compared to the Ixodes tick. Now, as far as the animal reservoirs, typically while they're transferred by the vector, which is the tick, the reservoirs in nature are going to be white-tailed deer as well as canines and dogs. So here are my two dogs at home, the Milos and Andy. They wanted to be included on the slide, so here's their token cameo. And the transmission of the tick bites, in addition to tick bites, you can also see transmission by organ transplantation or blood transfusion, although that tends to be quite rare. They're predominantly identified within the South Central and the Eastern regions of the United States, but it's important to know that ehrlichiosis does have a global distribution, and you will see it in other continents in South America, Africa, Europe, and Asia. As far as clinical presentation, again, very generalized symptoms. So you have fever, headache, malaise, you might have some nausea. Sometimes you will see a rash appear. However, that is not going to always appear with every case of HME. But you can also have instances of severe ehrlichiosis, which has meningoencephalitic involvement. You can see toxic shock-like syndrome associated with multi-organ failure, as well as acute respiratory distress syndrome. However, we typically only see these severe cases in immunocompromised individuals. Moving on to the second causative agent, which is anaplasma, which causes anaplasmosis or human granulocytic anaplasmosis. The most common causative agent is Anaplasma phagocytophilum, and the vectors are the Ixodes tick. So the Ixodes persulcatus group, which includes Ixodes scapularis as well as pacificus. And then the reservoir in the wild, again, deer, sheep, white-footed mouse, typical mammals that would be inhabited in these wooded and grassy environments. It's mostly found in the United States. However, you can find cases of anaplasmosis both in Europe and in Canada, again, in those warmer months. It is the second most common reported infection of rickettsial disease in the United States, second to only Rocky Mountain spotted fever. The clinical presentation mimics Rocky Mountain spotted fever. However, rash only occurs in less than 10%, whereas in Rocky Mountain spotted fever, you might have a rash occur anywhere between 50 to 70% of the time. However, these infections are often, again, going to be accompanied by leukopenia and thrombocytopenia. Okay, so for diagnostic testing, blood is the preferred specimen, and in rare cases of meningoencephalitis, CSF may also be a suitable specimen. Whenever we talk about anaplasmosis or ehrlichiosis, historically, we always tend to focus on the presence of those intracellular morulae. However, morulae aren't always going to be present in cases of ehrlichiosis or anaplasmosis. Further, while microscopy and morulae are often discussed in the context of maybe a board exam or test or teaching, in clinical practice, microscopy is rarely used for the primary diagnosis of anaplasmosis or ehrlichiosis due to its poor sensitivity. Instead, molecular methods such as PCR or even utilizing serological methods are almost always the diagnostic test of choice in clinical practice. Now, what about treatment? Again, vitamin D. Doxycycline is the preferred drug of choice for treating Ehrlichia and anaplasmosis. Okay, on to the next one. I hope I still have the attention of most of you here. A 76-year-old female underwent a liver transplant due to non-alcoholic hepatic cirrhosis. With a prolonged hospitalization, post-transplant, she received 50 units of packed red blood cells, 1 unit of platelets, and 2 units of plasma. 3 months into her hospitalization, she developed recurrent non-cyclic fevers, which persisted despite broad-spectrum antibiotic treatment. And then recent physical examination was pertinent for new altered mental status. What is on your differential diagnosis? Now, I know what you're thinking. You are thinking, but Ken, this isn't even a tick-associated case. And you are absolutely right. That's no tick. We are looking at a classical case of blood transfusion-acquired babesiosis, which babesiosis is historically and traditionally acquired through tick bites. So we can see here we have a thin smear, a Giem-sustained thin smear with these intracellular, almost ring stage looking parasites. These are your Babesia parasites. So Babesia, there are over 100 different Babesia species that are transmitted by the Ixodes tick. There are 3 main ones that are known and associated with human disease, and these are Babesia microti, Duncani, as well as divergens. And you have a nice little figure here from the CDC DPDX demonstrating your cyclical, your life cycle within the tick, as well as our reservoir animals, which tends to be the mouse and other mammals. Humans are incidental dead-end hosts, so when a tick latches on and transmits that parasite into the human, they typically kind of die off and tend to finish within that host, hence the term dead end. However, other forms of transmission that we can rarely see, but it does happen, is transmitted form from a blood donor, so a human-to-human transmission via a blood transfusion. And we actually saw one of these cases last year here at Indiana University, so it's not as uncommon as you think, which is why there's rather rigorous screening standards that go into blood products and donor screening laboratories. Another transmission method that's not often talked about as well is actually vertical transmission from the mother to the child. So again, very, very rare, but it does happen. So diagnosis, the gold standard for diagnostic test for Babesia are Giem-sustained blood smears. So we would work this up very similarly to how we would work up a malaria smear or a patient suspected with malaria. Morphologically, they are very similar to malaria. However, there are a few key differences to help you distinguish between the two. The first is that you'll typically see intracellular parasites. They tend to be multiply infected, which means that you'll see multiple parasites within a single red blood cell. Now, Plasmodium falciparum can do this sometimes, so this might not be the best differential to try and tease the two apart. However, if you look at the circle here on that second figure, you'll see extracellular parasites. So that is to say Babesia parasites outside of the red blood cell. This tends to be stronger evidence to suggest that we're looking at Babesia versus a malaria parasite, as malaria parasites tend to be purely intracellular. And then I think the kind of slam dunk diagnosis for Babesia is what the arrow is referring to here. So you're seeing like this formation of almost an X or a cross. These are referred to as the Maltese cross. So I have some Maltesers here. I have a Maltese dog, whatever memory mechanism you need to remember that term. But typically you'll only ever see a Maltese cross in textbooks or these like beautiful pictures on CDC. I've yet to see one in practice, so I wouldn't bank on trying to see this one phenomenon as your kind of home run hit diagnosis for Babesia. So as I'd mentioned earlier, there is quite rigorous screening for Babesia in donor screening labs. Molecular testing is only commercially available for donor screening. There isn't anything FDA approved for clinical laboratories to bring on and employ. As far as clinical presentation, you can have this influenza-like illness with fevers. In cases where the disease becomes a little bit more severe, patients may present clinically similarly to malaria and experience symptoms such as severe hemolytic anemia, thrombocytopenia, as well as severe organ damage. In terms of treatment, mild cases of Babesia will tend to resolve spontaneously on their own. However, if intervention is required, the drug combination of choice is going to be atovaquone and azithromycin. So moving on to our next case, and I believe this is going to be the last case that we discuss today. So we have here a previously healthy 7-week-old male residing in the upper Midwestern US who presented to the emergency department with fever and generalized tonic-clonic movements concerning for seizure. The child's parents recalled removing a tick of unknown species approximately 1.5 weeks prior to their presentation. Blood and urine cultures were ordered, a respiratory pathogen syndromic PCR panel was ordered, and everything came back negative. They performed a lumbar puncture, which demonstrated an elevated white blood cell count. They ordered bacterial cultures off of this. They did a herpes simplex virus or HSV PCR, as well as ordering a meningoencephalitis syndromic PCR panel, and all of these were negative. So what is on your differential diagnosis? So I would be remiss if I were to give a tick talk and I fail to present you all with at least one arbovirus case. And that is kind of what we're looking at here. So here is a list of arboviruses that are currently circulating in the United States. The viruses in the red text are denoting tick-borne viruses. So this particular case, which was published in the Journal of Clinical Microbiology by Dr. Ellie Thiel and some of her other colleagues at Mayo Clinic, this was a patient that was ultimately diagnosed with meningoencephalitis caused by Powassan virus. And I should mention that the patient ended up being successfully treated with supportive therapy, and they're doing okay. So it's always a little bit sad to hear when you have a case study of a young child. So I thought I would preface that. So what is an arbovirus? This was news to me a couple years ago, like maybe 5 or 6 years ago, that there's no such thing as an arbovirus. An arbovirus is actually a shortened term which combines arthropod-borne virus. So arbovirus is just kind of a term itself that encompasses specific viruses that have a vector-borne used for transmission. There's no arbovirus itself. So there are currently 5 tick-borne arboviruses that are known to cause human disease in the United States. The first one is bourbon virus. That's a fun one. Colorado tick fever virus, deer tick virus, Heartland virus, as well as Powassan virus. Now, all of these viruses have different taxonomical classifications. They're all RNA-based viruses. They all have different vectors of ticks, as well as some combination of mammal or bird reservoir in the wild, where they end up in humans as a dead-end host. But if I can draw your attention to this table here, I think the most important thing to note is the disease association. Febrile illness, febrile illness, febrile illness, febrile illness. You can see that there's such an overlap in symptomology that it can be really difficult to try and tease these apart from one another. So what do we need to do in order to be able to distinguish these? And again, the first thing to look at is the geographical region. So having an idea of which of these viruses is harbored and transmitted by which vector is a great place to start. So let's talk about each of these groups in a little bit more detail. Let's start with Powassan virus and deer tick viruses. They're both flaviviruses, and they're the only tick-borne flaviviruses found naturally within North America. Now, between 2009 and 2018, there was a reported 144 cases. These numbers have jumped up since, partially due because we're starting to look for these now, and there's improved diagnostic tests looking for them at reference laboratories. What's concerning, though, is that Powassan virus tends to have nearly a 10% fatality rate. So if left untreated and undiagnosed, there is severe risk for progressive disease. So the Ixodes ticks are the primary vectors for both, but it's worth noting that the dermacenter ticks, or the American dog ticks, are also competent vectors. So now we have a virus that's capable of using 2 different tick-borne vectors within the United States. So you can imagine what this means in terms of geographical range within the US. Clinical presentation, again, influenza-like illness with general symptoms. However, as I'd already mentioned, in severe cases, patients can go on to develop meningoencephalitic symptoms. There are currently no approved vaccines or antiviral therapies for Powassan or deer tick virus, and unfortunately, this is a trend that we're going to see with many of the tick-borne arboviruses that we're going to discuss today. So really, the best thing that we can offer is going to be a combination of supportive therapy and just therapeutic monitoring. So, Colorado tick fever virus, or colti virus, so colti Colorado tick. was first isolated from the blood of a patient in Colorado in 1946. The primary vector is the Dermacentor andersoni, so it's the other version of that American dog tick. Tends to be geographically restricted to kind of the regions within the Rocky Mountains, so both north and south within Canada and the United States. Clinical presentation, very similar amongst all the other arboviruses that I've already talked about, is these influenza-like symptoms with general fever. What's unique about Colorado tick virus is the fact that sometimes in patients you will see this biphasic fever. And what I mean by that is you'll have ebbs and waves of fever, and then it kind of resolves, and then the fever kind of comes back. So similar to what we might see in something along the lines of like Borrelia recurrentis. There have been rare cases reported of CNS involvement with Colorado tick fever virus. So again, it can be a disease that is very deadly and scary if allowed to progress. Unfortunately, similar to Powassan and deer tick virus, there are no available vaccines or antiviral therapies. Okay, Heartland and Bourbon virus. This is a Bangya virus as well as a Thagota virus for Heartland and Bourbon respectively. Between 2009 and 2018, there's been over 50 cases of Heartland virus and Bourbon virus reported to the US. Again, I think these numbers are a little deflated or masked in a sense that it's not really a reportable organism or at least a reportable disease, or at least at the time, and people just weren't really aware of it or looking for it. But if we look at like this map here on the right, so this is the distribution of Heartland virus as well as Lone Star ticks. Both of these viruses share the same vectors. So Amblyomma americanum or Lone Star tick. So again, predominantly found within the Midwest and the southern United States. However, you can see that there's been quite an expanded range here going towards the Midwest and all the way up the Atlantic East Coast in the United States. So there is a big concern for this to be spread again with global warming and climate change throughout the greater majority of the geographical US. Clinical presentation, influenza-like illness with general fevers. What's unique about Heartland and Bourbon, though, is this will often sometimes be accompanied by leukocytopenia and thrombocytopenia. And again, if allowed to progress, fatal cases have been observed with multi-organ failure for both of these viruses. And again, currently no available vaccines or antiviral therapy. So what are some of the challenges with tick-borne diagnostics? I think the first challenge is the fact that we've kind of seen on these last few slides is that there is so much overlapping symptomologies with several of the tick-borne illnesses. Many of these diseases will often present with very general symptoms such as fever or influenza-like illnesses. And this can be further complicated when there is no obvious rash or if the patient doesn't recall any sort of tick bite or a history of a tick encounter. There is currently a major lack of commercially available diagnostics for tick-borne diseases, with many of the FDA-approved tests being exclusively serological based. So we have the Diasorin Liaison, Lyme Total, we have the Biomer Uvitis, as well as the Biorad Bioplex available. And all of these are specific to Lyme, and they look at IgG, IgM antibodies. As we had discussed earlier, there has been an explosive growth in the geographic range of tick-borne cases. This leads to cases of acquired disease outside of a typical geographical region or where something was normally considered endemic, which may not be on the differential of our healthcare providers when they are trying to figure out what is causing this patient's illness. And then lastly, there tends to be a lack of expertise and stewardship of diagnostic tests for tick-borne diseases. And what I mean by this for both providers and laboratorians is knowing the appropriateness of which test to order based on the suspected pathogen and the clinical presentation or stage of that patient. So not just which test to order, but what kind of specimen type should we be ordering as well. This is a fantastic table from ARUP, which I used kind of as a cheat sheet during my training and fellowship, which reminds me of which testing disease typically has the corresponding tick vector, and then what the ideal or recommended test is for diagnosis. In addition, I also really like this flow chart that was published by Dr. Pantadosi, who's a practicing ID physician out of Emory University in Atlanta. This is a workflow pathway to look for arboviruses infections in terms of like what you should order, what kind of methodology you're using in terms of being able to get to both the definition of a probable case as well as a confirmed case of arbovirus. Okay, So what does the testing landscape look like? And I apologize, it looks like part of the figure is cutting off some of the words there, but that just should say laboratories at the top. So what does the testing landscape currently look like? Even with commercially available serological diagnostics, a majority of testing for tick-borne diseases a majority of testing for tick-borne diseases outside of microscopy are still performed as send-out tests for most hospital laboratories. So testing is often readily available at state and public health laboratories for both serological and molecular methods. Testing is also available at several commercial reference laboratories such as ARUP, Quest Diagnostics, Mayo, and LabCorp, and there are others on there which I haven't included. One thing to mention is if a lab is interested in bringing in their own molecular test for tick-borne diseases, there are primers and probes that are commercially available for purchase. These are available as analyte-specific reagents from companies such as Altona Diagnostics or Diasorin or even Fort Worth Diagnostics. It's worth mentioning, though, that these are not FDA-approved assays, and rather they are just a singular component of that test. So labs who wish to bring these on will also need to purchase the other components of a molecular assay, such as master mix or any other PCR additives that they wish to use. And they'll need to perform a full validation to establish performance, as well as satisfy their laboratory regulatory body. In addition to more targeted singleplex or multiplex PCR assays, there are expanded molecular testing options available. So these can include things like broad range PCR with reflex sequencing, either Sanger-based or next generation sequencing or NGS, or even metagenomic next generation sequencing from the get-go. So Carius is something that a lot of people have talked about. It can be used to identify some of these tick-borne diseases and viruses. Mayo Laboratories, as well as University of Washington, have broad range PCR available for ordering, in which you can pre-amplify with some primers, and then they can reflex it to Sanger sequencing or next-gen sequencing based on the quality of those reads. And then another one, which I didn't include on here, is Delve Bio, which is another company that offers next-generation sequencing from normally sterile sources. I believe they also have some targets on here that are capable of picking up some of these tick-borne diseases. I always like showing this figure here on the right. It was beautifully done by one of my colleagues, Dr. Lauren Franco, and her partner. And it is the REASSURED acronym by the WHO, or the World Health Organization. And the idea of this is these are the criteria. The REASSURED criteria is an acronym of different things that you want to look for in terms of implementation of a specific test. So something that you probably picked up on from this slide in terms of the testing landscape is that all of these tests typically take place in some kind of large reference laboratory, and there's not really anything available closer to point of care, whether that be a primary health site or a primary health clinic or even a hospital laboratory. So it's a nice inverse relationship between complexity and cost and accessibility. As tests get closer to the patient, you ideally want them to be simpler and less expensive, but what we end up seeing is tests closer to the laboratory end up being very complex and very expensive. And there's a little bit of a disparity for this in terms of test equity for tick-borne diseases that I think needs to be addressed. Okay, so in summary, I want to say that tick-borne diseases are clinically challenging, and we should care. There are many overlapping symptoms across these different tick-borne diseases, and it makes it very difficult for diagnosis. And if we're not looking for them, we're not going to know what's there. The expanding geographical range of tick vectors and the lack of standardization of arboviruses being nationally notifiable creates a lot of unique public health challenges. Again, we're seeing these expanded ranges. You might be a patient in the Midwest who might be positive for Lyme disease, but because you're not from Connecticut per se, it might not be part of the differential of your primary healthcare provider. So I think education and communication is very important to make sure that we are aware of this expansion of the geographical range, and also communication with our public health laboratories in terms of reporting these to the CDC and the relevant organizations to make sure that this data is publicly available. And then lastly, I think the big key here is that there is a lack of commercially available diagnostics for tick-borne diseases. So this really emphasizes the need for more diagnostic innovation, whether this be allowing us to bring tests into the laboratory off of a commercial-based platform, education with our providers in terms of asking them to look for these diseases when they're clinically indicated, and of course, diagnostic stewardship. We don't want these tests kind of ordered unnecessarily or like shotgun approached, but order the test when it makes sense and get the appropriate specimen when you can. So with that, I do want to thank again LabRoots for hosting this webinar today, Diastorin for inviting me and having me on to speak about it. It's something that I'm very interested in and I enjoy talking about. And with that, I would be happy to take any questions. Thank you very much.
Thank you, Dr. Gavina, for your informative and itch-inducing presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just type your question into the Ask a Question box and click Submit. We'll answer as many of your questions as we have time for. So let's go ahead and get started. Our first question asks, given the poor sensitivity of PCR in certain rickettsial infections due to the tissue-localized nature of these organisms, how should clinical laboratories prioritize sample types or select the most appropriate diagnostic method for early detection?
Yeah, great question. So I think continuing education and communication in the lab is key. So as you saw in the webinar, depending on the type of infection and the stage of disease, it's really going to dictate what specimen type is optimal for diagnosis. So in cases of like anaplasmosis or ehrlichiosis, which are part of the Rickettsiales order, blood should be fine. But in cases of like Rocky Mountain spotted fever, where tissue tends to be the better specimen type, you can communicate this with your providers and perhaps have a punch biopsy or other tissue specimens ordered, which might be better suited. Part of this specimen could then be sent, like if we're going with that tissue biopsy, part of that could be sent off to AP or anatomical pathology for staining, and then you could preserve some of that specimen for potential send-out testing for confirmation. I think it's all about making sure that the lab and the providers are really on the same page when it comes to tick-borne pathogens.
Excellent, thank you. We have a follow-up question for that question. The follow-up is, can you also speak to the reliability of serology-based testing, particularly in terms of sensitivity and specificity, and what the current standard of care looks like for Rocky Mountain spotted fever?
Yeah. So the gold standard of care for testing for Rocky Mountain spotted fever is serology. Now, specifically, it's going to be paired sera testing. So they test early in the acute phase, and then they take a second serum specimen a few weeks later, and they measure the changes in the IgG levels. Now, anything greater to or equal than a 4-fold increase in antibody titers is confirmatory for Rocky Mountain spotted fever infection. Now, while this is, a relatively cheap and easy test to perform, there are some substantial limitations to this. The first is that you can often see cross-reactivity with other rickettsial infections by this method, so it's not perfect. And then the second limitation, which I think is a bigger challenge, is that it has very poor sensitivity in the early acute phase. Again, it typically takes weeks to develop these IgG antibodies. And this is important because if you're not able to get a confirmed, this is important because you're not able to get a confirmed diagnosis until that second match serum is taken and you're able to compare the difference between the two. During this time point, when you're really waiting for that second serum specimen, it's important that clinicians should remember to treat as soon as they suspect Rocky Mountain spotted fever, again, because of the risks for progressive disease severity, rather than wait for the confirmed results.
Okay, thank you. This next question asks, with the increasing number of recognized tick-borne pathogens and their overlapping clinical presentations, how do you see the role of multiplex molecular panels evolving to address diagnostic needs while avoiding unnecessary testing?
That is a really good question. So again, it's hard because with these tick-borne diseases, there's really going to be an emphasis on who's testing it and where are they testing because of that geographical range. So I don't really think that there's a syndromic panel, you could create a syndromic panel that just tests all of them. And then unfortunately, depending on what state or what city you're testing in, some of those targets may not apply. But we're starting to see a trend in syndromic or multiplex panel testing that utilizes like a reflex technology. So an example I can give is there's a few assays out there that have a respiratory reflex assay where you can test for a few core targets and then you can reflex to a few others. I think something like that would be very valuable in a sense that you can have this syndromic panel for different tick pathogens and tick viruses. And then based on where you're testing geographically, you can kind of select which pathogens you're looking for specifically. Now, I'm not going to discuss what reimbursement or cost would look like for that test. That's an entirely different question. But I think something like that would play a huge role in terms of being able to get a diagnosis of these acute infections across the board.
Great, thank you. Our next question is asking, you highlighted several emerging tick-borne viruses such as bourbon, heartland, and powassan that lack widely available diagnostics. What practical steps can hospital laboratories take to remain prepared for these infections in endemic areas?
Okay, that's a fantastic question. So again, these tick-borne viruses, or arboviruses, I should say, they pose a very big public health challenge, again, particularly because commercial diagnostics just don't really exist. So that being said, I do think there are a few practical steps that labs can do to prepare for these infections. I think the first, again, is to collaborate with our clinical colleagues. So educate clinicians and communicate that these pathogens are circulating, make them aware what the clinical features are and what they should be looking for. So they can kind of get a little bit of a light bulb moment and they can notify us if they suspect that this might be one of those few cases. Another thing that hospital laboratories can do, if they haven't already, is to start establishing some kind of sample storage and testing pathway for when these orders start to come in. So an example of this could be to consider saving or freezing certain specimen types that come in for your routine standard of care in anticipation that they may be sent out later for reference testing for arboviruses. So knowing which reference laboratories you have available to you or what test your state public health lab might have available to you is very high yield. And I think these are two things that most hospital laboratories can do to immediately help themselves prepare for these infections.
Excellent. And we have a follow-up for that question as well. The follow-up is, given that no approved antiviral therapies exist for the powassan, deer, tick, heartland, or bourbon viruses, what clinical strategies are available to support and manage these patients?
Yeah, another great question. So I think early clinical recognition is going to be the most important. So to be able to identify, or to be even able to identify that the arbovirus itself is the causative pathogen. This would then allow us to, discontinue empiric therapy, knowing that it's not going to help. Then we can focus on supportive care, such as any potential seizure management or respiratory support, or even managing fluids and supporting any affected organs. At the end of the day, there's only so much that we can do clinically to support arboviral patients. And while this might be a little bit of a cop-out answer, I really do think that prevention strategies are going to be key, so we don't hopefully ever really reach this point with a patient. So again, preventative strategies such as using insect repellent or tick repellent, wearing appropriate clothing during those leisurely hikes through tall grass and the wooded areas, and then doing regular tick checks and then prompt removal of those ticks. So I would go home, watch a video on YouTube on how to properly remove a tick so you're not just kind of ripping its body off and keeping part of the tick in there. And I'm also only partially joking when I say this, but bring travel tweezers with you on those leisurely hikes.
Very good advice. Thank you. All right, our next one here, moving along, we have a ton of questions flooding in. So if we don't get to your questions during the live, keep submitting them. We will get to them, we promise. Our next question is, considering that morelli are observed in only a subset of ehrlichiosis or anaplasmosis cases, do you see value in incorporating reflex molecular testing following an initial blood smear review, particularly in acute cases presenting with cytopenias, fever, and elevated AST?
Yes, yes, certainly. What kind of terrible analogy can I pull out of my pocket here? If we see a bird that walks like a duck and quacks like a duck, just because it doesn't happen to be near a pond, doesn't mean we should rule out that it's not a duck. That probably just confused people more than helping them. But I think to try and answer that question, I think molecular reflexive testing is incredibly valuable, given how poor the sensitivity is for anaplasmosis and ehrlichiosis by microscopy alone. And to that point, like, again, you're not going to see those intracellular morulae all the time in every case. So I think having a secondary test or methodology to be able to screen for those is really important. So this is going to be doubly true if the patient has a history of tick encounters or is part of the endemic areas where those ticks are found.
Wonderful, thank you. All right, our next question here asks, is it beneficial to save the tick and have the tick tested for the disease?
Yes, absolutely. So if, sorry, I'm reading this a little bit backwards. Maybe not. I initially interpreted this as tick identification. So one reason why this might be helpful is knowing what kind of tick is in your area. So the proper way to do this and submit a tick would be to remove it with a tweezer, ideally freeze it, just to kind of kill it and then send it to a clinical laboratory. As far as clinical relevance goes to this, maybe not so much. So just because a tick latches a blood meal onto it, it might be harboring multiple viruses or multiple pathogens, but it doesn't necessarily mean that all those viruses or pathogens were transmitted to the patient or the host when that tick was latched. However, this can be helpful from a surveillance or a epidemiological approach, in the sense that you're getting kind of a field survey of what viruses and tick-borne pathogens are in your area. So I think there is some benefit to that. There are some programs out there by state public health laboratories where they actually go out into fields and they comb through the grass and they collect all the ticks and they mash it up into this yummy smoothie, and then they look into see what kind of circulating tick-borne pathogens are in the area. So there is some merit to it.
Wonderful, thank you. We have time for a couple more questions here, so I'll keep moving along. Our next question asks, since these viruses are all RNA-based, is molecular testing more reliable than serology in acute phase diagnosis, or are both necessary depending on the virus and the stage of the illness?
Yeah, that's a great question. I think, again, serology right now is largely going to be based off of IgG detection. So if we're talking specifically about the acute phase, then certainly. If we have serology that looks at IgM, I think it's going to be one of those things where you're comparing generally the sensitivity of IgM serological detection methods versus RNA or nucleic acid based detection methods, in which case historically molecular detection tends to be a bit more sensitive. But I guess in the way that this question was asked, I would say that they would be more reliable, generally speaking, again, because you're relying on, if you're going to take a serological approach, you're relying on IgG antibodies to be generated in that acute phase, which is generally just not going to happen so quickly. So looking for, the virus itself might be more beneficial in that regard.
Wonderful, thank you. Okay, our next question here asks, is antimicrobial resistance a concern with these bugs, and have there been cases of Lyme or RMSF that are resistant to doxy?
I think that is a great question. I don't think that is a great question. That is a great question. I would say off the top of my head, I don't know. I think we could probably do a historical dive into the CDC MMWRs to see if there's been reported cases of antimicrobial resistant Borrelia infections. It's an area that there's not a lot of information available for. So if you recall that there's not really a lot of AST data on it in terms of what is considered resistant, or what does this MIC mean as far as a treatment into the patient. So they'll kind of use it anecdotally. Like obviously, if you get a drug choice that has a higher MIC, you might rely on a second line drug just because it's been demonstrated anecdotally in the literature that patients will typically respond better to lower MICs. But can't really answer that question off the top of my head. I don't know, but it is a fantastic question, and I think it could potentially be a concern in the future.
Wonderful, thank you. And we have time to squeeze in just one more question here. This question asks, do we have any idea how underreported some of the arboviruses are, considering how nonspecific the symptoms can be, and since some less severe cases might go unreported?
No idea. Fantastic question, but it is a genuine concern because, as we know, like you had said, it's not always going to be a case of severe disease. Not all of these arboviruses are reportable at a state level, let alone a national level. So we don't know for sure. And it doesn't necessarily mean that if someone's experiencing a fever, their first instinct isn't necessarily to go to a hospital and to try and get admitted. Or if they do end up going to somewhere like urgent care or their ED, they're going to run their standard of care tests. They're going to run kind of their current syndromic testing panels that are available, which are not going to pick them up. So I think it's reasonable to say that there is a large proportion of these viruses that go underreported. To what extent, I don't really know. I think we're really just looking at the tip of the iceberg here.
Okay, thank you again for your time today and your important research. We would also like to thank LabRoots and our sponsor, DiaSorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay, and we encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.